DTHF Research Meetings, your deep dive into the latest in research.
Dr. Whitney Irie from Boston College's School of Social Work. And today she'll be speaking to us about acceptability, an implementation outcome very relevant and featured widely as an area of investigation in our work. Her topic today is power, positionality, and precision, deconstructing acceptability as an implementation outcome. So I'll briefly introduce Dr. Irie and then hand over to her for a talk, and we'll have some time for Q&A and discussion as well. Dr. Irie is an assistant professor at Boston College School of Social Work. She's a lecturer on population medicine at Harvard Medical School and research faculty at the Fenway Institute. She also serves as the associate director of the Infectious Diseases and Global Health Implementation Science Research Institute, known as Irie. Her research seeks to serve Black women through improving their sexual and reproductive health outcomes. Thank you for joining us so early. Dr. Irie, over to you.
Thank you so much for the opportunity. I'm not sure what you all are seeing. Are you seeing my
We
slides?
can see your screen. Perfect.
Okay, great. Wonderful. Thank you for that kind introduction. So without further ado, I'll get started talking about problematizing, I should say, acceptability. I'm just going to minimize Teams right now so I can hop right in. This work is a collective effort by myself and my colleagues, Drs. Elvin Gang, Corey Bradley, and Radhika Satarajan. And as I was, Chelsea kindly introduced me, these are my affiliations listed here. So here's an outline of what we're going to be discussing today. And first, we're going to talk about the prominence of acceptability as an HIV implementation science outcome. The next part will be borrowed roots. Then we'll go right into conceptually incomplete and incompatible. We'll talk about power and positionality, and we'll end with precision and purpose. Acceptability is a very common implementation science outcome, especially in HIV research. And despite its limitations in a lot of ways, it persists as central and dominant. According to Proctor, acceptability is the perception among implementation stakeholders that a given treatment, service, practice, or innovation is agreeable, palatable, or satisfactory. And this is from the 2011 paper, which is a foundational paper in implementation science, because this is where we first become oriented to what we call now Proctor outcomes or implementation science outcomes. Since then, here's some statistics on the prevalence of implementation science across literature. 52.1% of manuscripts examine acceptability. And this is Proctor's work recently. And compared to other Proctor outcomes that you all may be familiar with, fidelity, feasibility, adoption, and appropriateness, you can see that they are reported less frequently in implementation science literature. So there's a reason why we use acceptability a lot. And some of you are already thinking like, well, yeah, I have to measure acceptability, right? So there's this perceived necessity. It's really seen as critical for driving the implementability of a particular innovation or a strategy across organizations, among different communities, and for patients or people that we serve. It also has an impact on our research and funding. There are actual guidelines and funding agencies that strongly recommend, and in some cases require an assessment of acceptability. And this is further demonstrated in WHO guidelines, as well as the UK Health Research Authority. Acceptability to participants is a key ethical issue in study design. So they're really wanting folks to ensure that they are, tapping into this to measuring this outcome, and defining what is acceptable to participants helps make research ethical. So once again, reiterating the how critical and important it is for us to think about acceptability and actually use it in our work. We actually have policies and guidelines that encourage us to do so. Furthermore, it talks about how understanding acceptability is really important because we want to understand why, how, under what conditions communities would engage in this work, right? So the Nuffield Council on Bioethics really drives home, like, we need to understand acceptability because it's an invitation for people to let us know what they would like about this particular, intervention or innovation or the thing that's being implemented, right? And this is further articulated by UNAIDS and AVEC that it is important that we understand why and what helps communities engage in these trials in this particular example, which is the last quote at the bottom. So now I'm going to talk about, well, where did acceptability come from? This acceptability that these agencies are really encouraging us to measure in our studies, that we do measure a lot in our studies, and we're always looking at, where did acceptability come from? And it's very important to me as a scholar, like, central to my process is, if I'm measuring something, I need to know the roots. I need to know the ontological roots, the epistemic roots of everything that I'm measuring, so that, because that has implications for why I'm measuring it and what it could mean when I actually receive those data or I receive that feedback of that measurement. And so when it comes to acceptability, it has borrowed roots. It's adopted from clinical trials and treatment research. And acceptability, far before implementation science, was a huge indicator, like a assessment tool for effectiveness, uptake, and adherence and ethics in clinical trials, specifically pharmaceutics. From Proctor's paper, that's when it was really kind of integrated into the social science implementation science space. And even Proctor, in that paper that we talked about at the beginning of the presentation, stated that this is inspired by clinical and treatment research. And this is in part why our current conceptual frame of reference for implementation science, this is why it is slightly challenging for us to appreciate acceptability in the work that we do. A lot of us actually don't do research in this type of space, and we're still measuring acceptability in a way that's in alignment with its ontological roots. One definition of acceptability in the clinical trials and treatment research is really centered around this idea around acceptability being agreeable, palatable, or satisfactory. And how folks would assess that would be whether or not patients or stakeholders express this level of satisfaction, perception of ease, and willingness to adopt a particular intervention or participate in a particular activity in different type of research settings. So these similarities in definition are important, and I think that it does ground us when it comes to acceptability. Like, yeah, we do want to know if things are palatable. We do want to know if they're acceptable. We do want to know if it's satisfactory. So those are very much so important. Understanding whether or not something is acceptable is very important. However, it still is limited, and we don't take enough time to really sit with the limitations of acceptability. And this is when we start kind of stepping back from the clinical space and thinking more broadly as far as context. And when contextual factors are introduced, an assessment of acceptability becomes a bit more complex. In implementation science, we often deal with broader organizational, systemic, and social determinants that influence or determine the intervention or treatment uptake. And if we rely on a clinical trial and treatment definition of acceptability, we might overlook some critical elements such as power dynamics, cultural relevance, and social context. And so my critique is that we have adopted and adapted acceptability from clinical trial and treatment research, which is often and just intrinsic to its science, it is treatment and product centric. And so in doing that, we are limited in our assessment of the multifaceted interactions between interventions, implementers, and contexts. And so our transferring this concept from clinical trial and treatment, it limits its ability to reflect the diverse and dynamic nature of implementation environments. So we're bringing it in from clinical trial and treatment. However, we're not really challenging the extent to which acceptability, this measure of acceptability, is capturing our implementation environment, is really responsive to the folks who are making this assessment and where their positionality. And so my stance is that adapting a construct from any science or any practice alone is insufficient. It's especially insufficient if you're doing so without a proper power analysis. Which takes me into my next segment, conceptually incomplete and incompatible. My stance is that acceptability, as traditionally defined in implementation science, is fundamentally incomplete and incompatible with the complexity of HIV implementation science. It is in some ways oversimplified. And as many of us know in this space, it's acceptability and acceptance and serving the patients that we serve and the communities that we serve requires a lot more than a checkbox of accepting intervention or accepting a particular activity. And so we want to ensure that we're aware of how this reductionist view, this reductionist approach actually fails to capture the multifaceted nature of human behavior, social context, and structural barriers that influence the uptake and success of interventions. I love Second's work around acceptability and measure of it. It's a little blurry on your screen. However, it's from his 2017 paper where he breaks down acceptability in these different domains. And I'm presenting this because this work, 2017 work, still is very important, as it provides some important steps towards us better appreciating how multifaceted acceptability is. And sometimes in our measurement of acceptability, we are asking, is this acceptable or not, without really teasing out those sub-constructs that could make up a certain definition of acceptability, in this case, Second's definition. Regardless of our measurement of acceptability, we cannot deny the empirical challenges that we have with acceptability. So whether you're using seconds, whether you're using an actual psychometrically validated measure of acceptability, whether you're doing qualitative interviews, no matter what it is, we have all experienced professionally and in our space, and we also know personally and anecdotally that there's a very poor correlation between acceptability and actual use. We see this I always cite Menace study about high acceptability of female contraceptives versus preferences for condoms. And why is it that we see this disjointedness between this relationship, whether folks want to engage in it, and the precision? And that's often because acceptability is something that we feel more compelled to measure because we think it's capturing something more than what it is. And we have to properly situate acceptability and acknowledge that it does tend to set a low bar for measuring implementation success. A lot of people can build a research program around the statement, this intervention was found acceptable among this population. However, we know that acceptability is not a strong indicator of implementation success, actual use, or sustained engagement. And studies show these discrepancies between the reported acceptability and real-world application. We all have examples of this. And so this is once again reiterating the point that Acceptability is important, and while it may have high acceptability, we have to be aware of alternative ways that we can think about really what's driving, what's inspiring, what's shaping, what will sustain, what will improve the desire for folks to engage in this intervention or to sustain this implementation strategy. So this is where we go into power and positionality, because sometimes we wonder, why is it that individuals will indicate high acceptability, however, they actually don't want to use it? And when you ask that question, that you must be able to and must be willing to wrestle with power and positionality in our science. Power, privilege, and epistemic ignorance. Despite growing evidence highlighting its limitation, the continued use of acceptability as a dominant metric is rooted in power dynamics and epistemic ignorance. This practice is perpetuated by those in positions of practice, design, and other authority within scientific communities who often overlook the voices and experiences of those directly impacted by the implementation of HIV interventions. This epistemic oversight reinforces existing power structures and privileges certain perspectives over others, leading to a skewed understanding of what constitutes successful implementation. How? You're thinking, okay, how could acceptability reflect or be a component or driver of the agenda of those in power? What does that look like? And I'm going to show you a great example. But I do want you to know that when we're measuring outcomes and we come into the space as, community health workers, as scientists, as folks that hold a position of knowledge authority, resource authority, among many, a political authority, among many other positions, those voices that we want to hear and we want to center are very much so shaped by our relationship with them due to our power and certain power imbalances. And measures like acceptability might inadvertently capture those power dynamics because what group wants to say no thank you is not acceptable and risk the chance of not being able to participate or access something that could very much so benefit them in a meaningful way, indirectly, or secondary benefits or tertiary benefits. And let's talk about what this could mean specifically. I love this work by Kingori in 2015, and I'm not sure if you can see. Yes, you can see. Okay, so you can see the political cartoon. And in Kingori's 2015 article, they talk about the empty choice, which is a sociological examination of choosing medical research participation in resource-limited sub-Saharan Africa. And really what Kingori is highlighting here is, I'll read their words. In the absence of institutional action, researchers are left with the moral responsibility and burden of performing choice while knowing that not being involved in research renders healthcare, drugs, and qualified staff inaccessible to prospective participants and research participants with chronic conditions in some contexts. So there is this reality that saying this is acceptable, yes, I want to participate in this, is not saying that I am on board with the intervention, but what it's saying is that there's some aspect of this research program that could benefit me and my health and well-being that I'm willing to tolerate in order to have access to this space of great care, leaving folks with an empty choice. Here is an example. During a study on family planning in Rwanda, women sought out the research site with the specific purpose of being recruited, even without having attended any information sessions in the community, or even if knowing that they did not meet the inclusion criteria. As enrollment allowed access to cervical cancer screening and to free testing and treatment of STIs. So they sought out and went to research sites so that ultimately they can be screened and receive testing and treatment. Not because the research was so interesting and they thought that was necessary for the community. Some folks may have, but in this instance, it's really highlighting the desire and need to actually engage in high quality care services, while also in this research context, without really having a interest or prioritizing the actual research agenda. 6 dimensions of research trial acceptability: how much, what, when, in what circumstances, to whom, and why. One of those dimensions is how acceptable is the trial. And in this study, it was a wonderful qualitative study on pediatric influenza vaccine trial in Malawi. And Gooding and colleagues asked people about these different dimensions of research trial acceptability. And someone answered to this question of how acceptable is the trial, tolerance or satisfaction. I love that dichotomy, by the way. I don't think the process is good. You go today and they collect blood. You go another day and they do the same thing. So I see that they would drain blood from her body. So we just go there, but we are not happy deep inside our hearts. We read this quote, and would someone code this as acceptability? If you were looking for acceptability, they're just like, hey, we're going to go there, but we're not happy about it. So is that still acceptability, or is it tolerance, tolerability? And so here, this is why we have to be able to be aware of the complexities of the work that we do in the settings that we're in. The act of people actually going and doing does not indicate that it is acceptable. And it does not indicate that it's satisfactory. Sometimes folks are tolerating it because they want to go there because they know that their child in this instance is receiving good care. The mother planned to continue participating because she thought the trial would benefit her child's health, saying at the next appointment, I will just be strong. If this is an indicator of acceptability, it is one that I do not think we should accept. And I think that this type of evidence and this type of research around acceptability, tolerability, satisfaction, it should really help kind of unearth for us the reasons why we ask about acceptability, what type of measure are we looking for, what type of indicator of implementation success are we looking for, and in this instance, at what cost? Are we sacrificing satisfaction for engagement? And is that important in some instances? And sometimes it is important because there's urgent critical need for folks to kind of engage in healthcare activities that are not their favorite, but they know would benefit themselves, their families, and their communities. And so again, this speaks to the complexity of acceptability that to date we have not really faced and interrogated as an implementation science. Unacknowledged actions and unintended consequences. I really appreciate Anthony Giddens' structuration theory. And using structuration theory, my position is that it becomes evident that unexamined and unacknowledged actions in the use of acceptability metrics lead to unintended and often detrimental outcomes. So when we don't interrogate and think deeply and critically about our use of acceptability metrics and the implications of its use, it can actually lead to unintended outcomes and in some cases very detrimental. In real time, the uncritical reliance on acceptability measures contributes to implementation failures, which is far more common than implementation successes, as many of us know in this space, because the metric does not accurately predict or correlate with actual intervention uptake or sustained use. And so this should prompt for us a disciplinary self-critique as implementation scientists. And so as a field, the implementation of acceptability, we have to begin to really step back and assess, its utility in measuring implementation success. How do we, with acceptability or other alternatives, account for social conditions and and constraints that elicit a behavioral response of high acceptance despite low interest or in low intent and or just simply no engagement. Does the positionality and power of scientific communities in their approach to assessing acceptability elicit incongruent responses? Is it something about our power and positionality as implementation scientists that actually drives this incongruent response? And is acceptability the most appropriate and precise concept that would indicate actual use or actual uptake or actual implementation success? These are the type of questions that we have to pause and ask ourselves as implementation scientists. So again, some critical examination and some critical questions for examination. The adequacy of acceptability. Is it necessary for measuring implementation success? Methodological individualism. Does the focus of acceptability from methodological individualism distract from sociological drivers like power and positionality? And exploring alternatives. Has the focus on acceptability overshadowed other constructs and methodologies from marketing, economics, and design traditions? We need to reevaluate the role and utility of acceptability in implementation science as a dominant outcome metric. I'm not at all purporting that we need to completely abandon it. It's useful in many ways, but right now it's quite dominant. And as we talked about earlier, in many cases, guidelines require it, and we should approach it in a way where we can more appropriately situate it and situate its implications and when it comes to power and when it comes to driving our assessment of implementation success. Is useful, but it should not be a dominant indicator of implementation success. Precision and purpose in theory and measurement. If the intent is to maintain the status quo, the practice of using acceptability as a primary measure can continue to thrive. However, the goal is to resist. Our goal is to transform current practices. Therefore, it is imperative to identify more precise and meaningful metrics that reflect the true desires, interests, and willingness of implementers and beneficiaries. Standpoint theory, Harding, and I have the 1993 and 2004 citations listed here, offers a very valuable theoretical framework for this endeavor. Standpoint theory emphasizes the importance of considering the social location, identity, and position of agents and implementers, which inherently drive their actions, shape their perspectives on context, on strategies, innovations, and necessary practices to support successful implementation. And using that framework, I'm going to offer some alternatives to acceptability that might better indicate, might help you better examine, explore, and in some cases determine implementation success. Usability. Usability is drawn from human-centered design, and it focuses on the extent to which people can reliably use a system to achieve their goals without error, safely, and with, an enjoyable experience. Lyon et al. Really breaks this down in their piece, in their 2021 piece about usability and human-centered design and center and joy. So some factors of usability that are important would be intuitiveness, clarity of instructions, and the overall user experience. Some strengths as an implementation science outcome would be that it would help us bridge this gap between theoretical acceptance and what we think about acceptability theoretically, like, oh, I accept it, I'm happy with it, this is great, I want to use this tomorrow, and practical application. It ensures a smooth transition from theory to practice, enhancing sustained implementation, and it directly impacts user satisfaction and engagement, which is critical for long-term success. Sensitivity is an alternative to acceptability. And here, is defined as the extent to which a strategy or intervention respects and aligns with the cultural values, belief, and practices of its target population, organization, or communities. And this is a definition that I am offering. And the contextual sensitivity would be favorability of a strategy or intervention to the specific social, economic, and environmental context in which it is implemented. So we know that we all know in our work that we can't transport interventions across different settings without really thinking about, well, what does it mean in this setting, without being sensitive to that context. And if we were to use an alternative measure or a measure alongside of acceptability, sensitivity will offer us an opportunity for us to say, okay, what is it? Is this favorable based off of the culture, based off of the current social climate, economic conditions, environmental constraints are facilitators? Would this actually be something that we'll be able to integrate with ease? And so sensitivity kind of offers that really multifaceted, very tuned in idea of what acceptability could look like as an outcome. Another alternative is to look at, instead of acceptability, look at preferences. And in my 2024 paper about implementation science and preference, we talk about a lot of different type of preference research methods, such as discrete choice experiments and best worst scaling. We also know conjoint analysis, but this is a very viable way for us to think about how can we approach acceptability by asking about, well, what would you prefer? So less of, well, offering an empty choice of, well, you know, here's what we have here. Do you accept it? And more so of, you know what, here's some ways that we can imagine and envision, or that we can look, you know, logistically offer this. Here's some variations. What would you prefer and why? What are you valuing over this set over another set of options? And we have definitely seen an increase in discrete choice experiments and best worst scaling in public health and medicine over the last decade or so, which is great. And I do think that it will be a very strong alternative to acceptability, and something that we should consider normalizing in our research design if we want to know whether or not the folks we're working with are actually going to, you know, implement and sustain a lot of the strategies that we are co-identifying and co-developing with them. Then we have appreciation. And appreciation, or appreciative inquiry, focuses on identifying and building on strengths and successes. So it shifts the focus from problem solving to appreciating, well, what works well, and how can we ensure we protect this and we support this in order to foster positive change. And so instead of, so I like this part of appreciative inquiry. They use this term, the best of what is. And so it's really asking communities, you know, what might be the best of what is? What's the best of what is right now? What do you want more of right now that's really working well? And it promotes a more holistic and appreciative understanding of implementation impact. Here we have this intervention design. What's working well with this? What do we want more of? What do you like about this? And they look at it and say, wow, I really like that you offer childcare during this. Or I really like that you take a holistic family approach. That's appreciative inquiry, and there's a science behind it. And it can be used to better approximate ourselves to whether or not we're going to have successful implementation outcome. And then there's delight and joy. And Chituri, 2008 and 2007, and some more recent work talks about this when it comes to delight by design. Moving beyond acceptability to measure delight and joy can enhance understanding of user experiences, focusing on positive emotions and satisfaction, providing a richer picture of intervention impact. And then we get into the hedonic and utilitarian benefits. And so the utilitarian benefits are all about safety, right? So what's going to fulfill our basic needs, what's going to be functional for us, what's going to help us avoid pain. And that's what we tend to really measure and focus on when it comes to our interventions, and as well as our assessment of whether or not individuals, implementers, or communities will want to take part in our intervention. However, and that leans towards the effective side, right? So effective, like, is this going to do what it needs to do in order to reduce pain, in order to help you avoid pain, in order to keep you safe? And then there's the affective. And I'm a social worker, so this really speaks to me. But this is the affective, which is, how do you feel about it? That, and not just how do you feel in a critical or negative way, but a level of enjoyment and pleasure. What is it that you enjoy about this? What is delightful about this that you want more of? And I guarantee you, and we all know this, if you find delight in what you're doing and what you're engaging in, there's a pretty high chance that you're going to continue to do that. And you're going to do some things necessary in order to sustain that. However, to date, we have yet to really, really appreciate, center, formalize, and use this type of approach in implementation science. Yet we wonder, well, why aren't the implementers doing this to fidelity? Why don't we have implementation success when we haven't really taken some time to appreciate effective, but better know, examine, and center affective? And the alternative to acceptability, which is measuring delight and joy, once again, I love this piece called Delight by Design, offers us this framework to think about what does it look like to really measure, assess, understand delight, pleasure, joy, the hedonic benefits as a driver of implementation success. So in review, we've gone over the prominence of acceptability as an HIV implementation science outcome. Most important is that its prominence is by choice, our researchers' choice, because we know that it is one of the primary implementation outcomes that are used. We know that a lot of other people use it, so we have a lot of evidence to support and to justify our rationale for using it. And also there are guidelines and professional practices that require or strongly encourage our assessment of acceptability, despite the fact that it is not a strong indicator of implementation success. Second, we talked about borrowed roots, how one of the reasons why there's this incompatibility with acceptability and implementation outcomes is that the term, the approach to acceptability is coming from clinical trials and treatment research. And part of it is part of that limitation, the weakness of that is it does not leave a lot of room for the complexities and the dynamic nature of social science research, public health research, where we're in these contexts that are not necessarily constrained by design the way it is for many trials and treatment research, at least the trials and treatment research that shaped our current use of the measure of acceptability. Then we talked about conceptually incomplete and incompatible. There's some great work detangling acceptability into multiple subconstructs. However, across the board, no matter how we measure acceptability, it still is not compatible with what we're seeing in the field, what we're seeing as far as outcomes. And so this is less about readapting, remeasuring, creating a new measure of acceptability. And it's more about, well, how can we think about this differently? Acceptability will have its place in implementation science. And we need to ensure that there's some adjacent constructs that allows us to properly capture what's important for us to help determine and facilitate implementation success. Then we talked about power and positionality as one of the reasons why to date acceptability is such a popular outcome, and how it's important for us to do a disciplinary self-critique and step back and acknowledge the ways in which our power and our positionality actually drive high acceptability responses despite low interest. And we talked about the empty choice and how by design in certain settings, folks are likely to say something is acceptable and or volunteer their time to engage, not because they have a commitment or interest in the science or the research we're doing, but because of the benefits of the healthcare provision that they will receive should they engage. And last, we talked about precision and purpose in theory and measurement, and talked about how there are other constructs from other disciplines and sciences that allows us to better understand, what would make something important, a priority, usable, implementable, how people kind of engage and rally around, develop loyalty in, investment in. So when we are far, far out from communities that we serve, and the community is operating in their ecosystem, their social system, it's normalized and it's embedded because they have found some benefit of it, some joy with it, some positive impact from it that really helps, that drives and sustains implementation success. And with that, this is my information, and I look forward to discussing.
Thank you so much for a thought-provoking talk, Dr. Irie. I see we have a few more people that have joined, and we're lucky to have 15 minutes left for question and answers and discussion. So would anyone like to ask a question? Everyone's quiet. I might ask a couple to get us going. So thank you so much. I mean, I think I appreciated the historical perspective and critique. I think looking back on measures before we continue to replicate them is such an important way to practice reflexivity in our work. So thank you for sharing that with us. And I was really taken by this idea of kind of a measure being previously used in trials and treatment procedures in a highly controlled environment, yet transplanted as a measure in so many disciplines, right, at such significant scale and prevalence. You even gave us statistics. For those that weren't here at the beginning, Dr. Irie said that acceptability is used in more than 50% of manuscripts on implementation science, which is pretty staggering. So I wanted to ask a couple of things. I think the first is, have you come across similar trends in feasibility and fidelity, which I know kind of are close second and third, because I couldn't help but ask myself the same questions about some of those, especially when we're thinking about the complexity of the organizational environments that we're trying to situate new implementation strategies in, that you may ask a young woman an acceptability type question and try and achieve a measure and outcome, but then you may look at a healthcare worker and ask them or use a scale or a quantitative measure to understand fidelity and feasibility. And how do you kind of bring those strands together when their roots are similarly borrowed and potentially problematic, and you're trying to synthesize these complex insights with the power and positionality problems that you raised? So I thought I might ask that to start, and then I have a couple of others if others don't have any. Thanks, Whitney.
Absolutely. Yes. You know what? I was coming for all of Proctor outcomes. I feel like I have a presentation for all of them.
Great.
And, but to say, I think that I think nothing is above critique. And I think if as I stated at the beginning, when we are serving and working with communities, we should have a very firm grasp on what we're measuring, why, and where it comes from. That historical lens is very important, and some communities have the privilege of not needing to interrogate that because it's likely was rooted in systems that benefited them. With that said, fidelity and feasibility are definitely next on the list. I will tell you why acceptability was first. Acceptability was first because amongst all the Proctor outcomes, it's the most subjective. It's really the most subjective. It's the most popular, which is interesting because not only is it the most popular, but it's the most. So it's really, I felt as though it required I think it level set. It let us know, like, this is how we're going to approach this work, and this is a very fair and important way that we can start thinking critically, which I think is, think it's always important, and I love, but also productive. Like, it's good to critique, but how can we move forward? Like, how can we build on this? With that said, going into feasibility and fidelity, what is feasible to in the same organization to one person compared to another person, and we can measure this based off of proximity to power. Someone in power might see feasibility completely different than someone who is a bit more distant from power in that particular organization. And so feasibility alone requires a very detailed power analysis. We need to understand that, because feasibility also does not necessarily determine implementation success, and also low feasibility does not mean that it's still not meaningful in that space. And I think that sometimes feasibility offers this opportunity for people to this unfortunate opportunity, missed opportunity for lack of investments or divestment because it hasn't been deemed feasible, when in reality, we're just not done imagining. And I think that we have to think about feasibility in that way. What are the components of feasibility that are important, and what, just kind of similar to the hedonic benefits, or even the appreciative inquiry. This may not be feasible in this way, but what is it about this that we need to maintain, or that we need to sustain, that is slightly more feasible? And so feasibility is definitely next. And then fidelity. I think that fidelity is very counterintuitive to me for implementation science. I think that protocols and structure is very important. However, in real world settings, there's a level of like fluidity. You have to be agile, and sometimes fidelity is not the same as agility in a lot of different ways. And I think that we have to be careful with these clinical trial concepts like fidelity that limits the flexibility our settings have and that actually practice, in order to kind of meet these metrics that are just relatively not critical in our day-to-day in some cases. So yeah, I'm going down the list. We're going to go down the list and offer a meaningful, productive, constructive, but a deep critique of these outcomes, because we have to know what we're measuring and why we largely see significantly more implementation failure than we do success. And we don't talk enough about that. Part of it's because how we're measuring the outcomes.
Right. We're missing the point.
Right.
Thank you so much for that thoughtful response. I wanted to open up the floor to others in the last 8 minutes.
I saw Mildred gave me a heart.
Yeah, thanks, Mildred. There are a lot of colleagues here that are working with young women, and I know that you're also working with young women, and some of the colleagues here are working on PrEP demonstration studies, so all very relevant. Would anyone like to ask a question? Otherwise, I can ask one more. Everyone's very quiet. Nadine, do you have any?
There's no questions in the chat, so I think you can go ahead and ask your other question.
Feel bad.
No, here's the time. We can all learn.
Okay, great. So I'm just thinking a little bit again about the work that I know some folks on this call have done and are involved with. And so we are actively using discrete choice experiments and looking at preferences in some studies. I'm also familiar with strengths-based methods, especially appreciative inquiry, as you mentioned. But the need and the opportunity to center delight and joy really resonated with me. I'm not sure others, maybe you can heart or put your hand up if you heard that and appreciated that. I couldn't help but like, then think about like medicine taking, right? And your work on PrEP. And I'd love to hear about how you're kind of juxtaposing how, medicine taking until, of course, now we've got Len and we have the ring and everything. But, these are still things that involve a lot of effort and adherence and repeated behaviors, and how how have you thought about that? And can you share any examples of measures, whether qualitative or quantitative approaches, where you've started exploring that delight and joy outcome in that type of challenging implementation research?
Yeah. Oh, thank you for your question. You know, this is so important. I think so. In the U.S., my work focuses on PrEP uptake among Black women in the U.S. And it's very interesting because, you know, years ago, almost 20 years ago, a study came out that said Black women found PrEP acceptable. And it's probably one of the highest cited Black women in PrEP like sentence ever, because it had to have really like catapulted so many research programs based off of that alone. And yet to date, PrEP uptake among Black cisgender women in the United States is like devastatingly low. However, we have these, you know, we've measured the acceptability, is acceptable, is acceptable. And so some very important work was done recently, partly with you know, orgs like ViiV and researchers in general, really to really sit in and properly situate what does it mean for a Black woman in the US and her sexual health and relationship with, you know, just HIV prevention and care and communities and stigma. And something that has really been unearthed and it's become central to a lot of the work that many of us are doing now is that it's less about risk and it's more about reasons. And there was this huge campaign from risk to reasons because, you know, for a lot of the researchers at that time, it was quite profound. It's just like, yeah, it's not about risk. However, our public health model has been to really kind of harp in on the risk, which is that utilitarian approach, right? It's just like, you're at risk, you need to be safe. You're at risk, you need to be safe. And less about that hedonic, that pleasure, like, well, what's your reasons? And so when it comes to PrEP as a medication and taking PrEP every day as a medication, a lot of Black women in the United States, when asked about it in terms of like what would make this, you know, something that you want to integrate, would be that ease, but also there were some things around like self-care. What if it was a tea? What if it was something that we did as part of this? What if it was integrated into this space? And you can't deny the component of pleasure and taking care of yourself and just like that feel goodness when people start bringing up these themes of self-care and how far away the approaches to date when it comes to women in contraception or folks who could become pregnant in contraception or engagement in biomedical prevention technologies have not even begin to start thinking about, well, how can we focus it specifically in among cisgender women, like how can we kind of focus this, you know, using a pleasure perspective. And so I think, so to answer your question, that has really kind of shaped how I, even the type of questions that I ask around PrEP. Are there measures currently that we are using in public health or implementation science that can really capture that? Not to date, but someone on this call could likely lead the charge in developing and validating a measure. There are some sexual I did a there are some sexual satisfaction measures that are being used in addition to kind of looking at PrEP uptake and everything. So they are there, and people are integrating it into their work. The extent to which we are specifically tapping into delight, we, you know, tapping into, you know, that affective joy and that driving of pleasure. I think that there's some ways to go. However, for instance, ASEC, which is a national organization here that focuses on sex education, counseling, and therapists, they have a huge body of work around ensuring that, you know, folks are using language, are thinking about this in a way that really centers feeling good and being in a safe space while feeling good when it comes to your sexual health decision making. What I would say about like the medication portion of it is very interesting because implementation science has largely been situated as a behavioral change type of science, and that's most of the founding group of implementation scientists are mental health behavior scientists. So it kind of makes sense. I think that that limits what we are kind of where we're intervening. It's not about taking a pill every day, and it's not about getting a shot every few months. And it's more about what's my lifestyle and how's this supporting the type of the lifestyle that I have. And when we shift our gaze away from the behavioral and more in terms of like the context of lifestyle, I think we'll better understand intervention design and on another level, and then we'll better understand how to implement those intervention designs. So with that said, a lot of my work really does focus on, okay, you might want to take it every day, you might not want to take it every day, but what is it about your lifestyle that really prompts you to say, I'm a PrEP user, I am someone who does this, I am someone who does this, and how does that align with your PrEP choices? Oh, I'm someone who does this only during the summer because I feel a bit more liberated because I travel more and I want to have more sexual experiences. Okay, so there's a seasons here. So then I kind of, I code that as seasons. That's something that's important. So my intervention design and my implementation strategies will be in alignment with that. And so there are just these different ways that we can approach it. But I would say for implementation science, it's really underdeveloped. And there's an opportunity, colleagues are in this space right now, especially with PrEP implementation science, for us to better explore that space and build that body of work. It's needed.
Thank you so much for those very thorough and inspiring responses, especially the call to this group to maybe lead the development of our own measurement tools and to update you along the way since you inspired us. There's 1 minute left for questions if anyone wants to raise their hand. Otherwise, we'll close for the day. Mildred took her microphone off. Your stage is yours, Mildred.
Hi. Hi, thank you so much for this. I want to just highlight how powerful it was and how informative it was. And I just kept thinking, what question do I have? But it's more of like, I feel empowered and I have ingested so much information. But I think I want to take the opportunity to also hear from you in terms of like the practicality. What advice would you give researchers like us working with young people when it comes to ethics? Because we talk about this, and I'm looking at the review that you just ended up with, where point number 4 is speaking about power and positionality. We speak about this all the time, and it's always been our main concern to make sure that have we covered everything. And with this information that we learned today, what advice would you give us? Like, is literature review enough? Is our perspective and data analysis enough? Is there anything that we miss in that we can make sure that we cover this? Because it's very powerful that we don't leave unacknowledged actions, and the things that you have listed, I found them very powerful and really comes close to the passion that we have in the line of work that we do.
Yeah. Well, I thank you for that. Thank you so much for that, Mildred. And when it comes to ensuring that we're kind of embedding a practice of awareness around our power and positionality, especially from an ethical standpoint, it's all of the above. It's the literature review, right? It's the group meetings where you're practicing reflexivity, when you have it not only where you can do it speaking with each other, but also written so that you have some sense of anonymity. And then it's also the community engagement and centering and empowerment structures. And, I'm going to start with the literature review. And I just want to say this because I think that is probably the most underutilized when it comes to power and positionality. And my hope is that this presentation about acceptability, which I've had the privilege of doing probably about 3 times now, my hope is that it demonstrates the exercise of how can we better interrogate ontological roots, and in doing that we should be ethically charged to do that. Outcome or measure or construct should not be used in our work, especially with our communities that we serve and we care so deeply about, with the sole justification that, well, we used it last time, or this person used it in their study, and things of that sort. Every person on the team should know what this construct means, where it was birthed, and why it's appropriate in this space. If it was birthed in the States and we're using it in Uganda, baby, we need to talk about some things. Like what makes us so comfortable with using this construct and this measurement here, and what, and we could justify like, well, because this and this, and or we could say, you're right, we could still use it, but we should probably supplement it with something different. So I think that there's a way that folks have been doing literature reviews for a very long time that is actually not really getting as deep into just kind of like that ontological epistemic, like where did this come from? What did this mean? And if we start there, I think ethically we would be in a better position, because, we would start, alleviating some of that power of having a privilege of just using whatever we want to use, because that's power. Oh, well, let's just throw this in here. Oh, what about this? Let's just ask about substance. That's a power move. And part of us really relinquishing that power is saying, wait a minute, no, we need to properly justify this, and we need to know where this came from and why we're using it here. And I think that's a start. That's a whole dissertation. Like literally, I'm not saying that you have to, but I'm just saying that practice is so rich. So I will always start there. I will always start there. I hope that helped, Mildred.
Thanks so much for the question, Mildred. Thank you for giving us 5 extra minutes, Dr. Irie, and for such a rich and vibrant conversation. And you've really opened up our eyes and minds. So we hope to keep in touch. And thank you again for your time.
Of course. Thank you so much. Bye, everyone.
Bye, everyone. Have a good evening.
DTHF Research Meetings, your deep dive into the latest in research.